You're listening to Beyond The Endpoint, a podcast from the Duke Clinical Research Institute. In this series, we're demystifying clinical research and answering your pressing questions about health and healthcare. You can find our full episodes at dcri.org/BTE.
Hello and welcome to Beyond the Endpoint. My name is Dr. Emily O'Brien. I'm a population health researcher here at the Duke Clinical Research Institute, and I'm joined here today by my co-host, head of cardiology at Duke Med and DCRI faculty member, Dr. Manesh Patel, and our special guest for today, Jenny Cook.
Thanks for the introduction, and I'm excited that Jenny is going to be joining us for this first part of today's discussion on hypertension. Jenny works on engagement and communication, and we should have an interesting conversation today.
Manesh, before we dive into today's topic, I have a confession to make. So, for a long time, the last 8 years, I've worked with a lot of cardiologists like you. And something I don't let you know is how terribly, deeply in love I am with salt. And whenever we talk about hypertension, I really want to find solutions, but I really don't want to give up salt. I think my confession is you don't realize that when I'm eating dinner or lunch out with all of you, I don't put on nearly as much salt as I do normally.
Look, I have family. My wife's family puts salt on food before they've tasted it. I'm confused when I see that. I'm like, don't you want to try it first? But they're like, however much there is, it's not enough.
I put it on fast food.
Wow, that's deep.
I load it up. And so something I've always really been interested in is prevention of hypertension and treatment of hypertension and salt. And it gets kind of confusing. And sometimes I think there might be some misinformation out there. What do I need to know, not being a cardiologist and just being a person who loves salt, but who most of my relatives do suffer from hypertension, and I probably am at risk?
And this is going to be a great conversation around this, I think, because there's a lot of conversations, and I know Emily and then our guests are going to get into this with what's an association versus what's causation. Some people want to know, I noticed that when a lot of people have salt, they have high blood pressure. Does that mean that eating salt causes high blood pressure? And I think we'll get into one of the interesting studies where there's been some substitutions of the components of salt that have shown us that sodium chloride, which we think of as salt, is not only associated, but causing hypertension and some of the downstream effects. Because when we were able to change some of those components and make it potassium chloride, we can actually see patients' blood pressures come down and we can see them have less events. That doesn't mean everyone responds to salt the same. And it doesn't mean that all salt is bad, but we do know that we probably have way more, I would say, salt in our diet, in the American diet, than we need, certainly in fast food. That is an important message. Now, there are people who love salt and hopefully don't have high blood pressure. And that's okay. I think as we age, we just have to keep paying attention to our salt intake.
So before we introduce our guest, maybe you could give us a quick definition of what is hypertension. What do we mean when we're talking about prevention and treatment of hypertension?
High blood pressure or hypertension is the diagnosis based on the blood pressure that we get on people. And we can go deeply into how you're supposed to do that. But importantly, we don't often do it in the best way, which is after people have emptied their bladder, they're not stressed, haven't just drank coffee, they're sitting with their arm at the level of their chest and they get their blood pressure taken. That blood pressure, when it's over 130/80, is high blood pressure according to the guidelines. There's been some confusion in the past. Some people say, well, I thought it was 140/90 and some of those numbers. It is above 130. And that's the top number, the systolic number, and there's a diastolic number. And we know that as these millimeters go up, your risk of some of those cardiovascular events go up. And it's fairly linear. Small increments can lead to significant lifetime risks. The other thing about high blood pressure or hypertension is that you don't feel it. You're walking around with a blood pressure, but unless it gets really high, you don't feel it. And so people can have this disorder or this problem without knowing it. The diagnosis requires you to test it a few different times, but once you've had a few of those tests that show that number is above, then we get into the things we do to try to prevent you from having issues with it.
And by issues, when we say we're treating hypertension, what we're really doing is trying to prevent a heart attack or a stroke or other bad events like that, right?
That's right. I should be more specific about the language when we talk about it, because people think about high blood pressure and go, well, yeah, but is that really bad for me? Everything from heart problems where your heart doesn't beat correctly and you get something called atrial fibrillation, to heart failure where it's not squeezing well, or more importantly, even kidney failure. These kinds of things have longstanding quality of life impacts on people's lives.
I'll just add a little bit as someone with the population health sciences hat on in terms of the prevalence worldwide. And we think about, based on the definition that Manesh gave, how many people this affects. It's 1.3 billion people. And unfortunately, we have pretty poor rates of control in the US. It's pretty amazing because we have a lot of therapies available to treat this problem, something like 200 drugs across 8 different classes, and more coming out every year. But we're still grappling with this problem of achieving widespread control. And I think it just really speaks to how complex it is, that it's not just about salt, it's about even genetic predisposition. I think of my husband, who likes to tell the story that his mother found him when he was 3 down licking a salt block in their basement. So my family's on the spectrum of like adding salt to the food before you eat it. So yeah, I think many of us are struggling with some of the implications of this risk factor and how we best approach it.
Yeah, no, listen, I don't want to throw shade on anyone who puts salt on their food before they eat it, because I routinely put spice or any type of hot sauce on my food before I eat it. So I know that there's preferences for sure. I want to introduce really a star person. We're excited to have Dhruv Kazi, who's an associate professor at Harvard Medical School, associate director of the BIDMC Smith Center for Outcomes Research in Cardiology, and co-chair of the American Heart Association International Committee. I'll just say Drew's an amazing person. He goes by Kazi, and he's a interesting mix of a cardiologist, a health economist, and somebody who's really interested in how we make policy to change the way we take care of our patients. So, Kazi, thanks for joining us.
Thank you for having me.
I know you and Karen Joint-Maddox and others had a recent really important paper from the American Heart Association looking forward to 2050 on the impact of what's going to happen with cardiovascular disease risk factors and population effects. Maybe you could just give us a sense of some of the highlights from that and what role hypertension plays in our future unless we do something about it.
Yeah, thank you, Manesh. As a part of that project, we looked at heart disease and hypertension in the US in 2020 and projected it out through 2050. And the top line, if we just focus on hypertension, it's a highly prevalent condition, 128 million US adults with the disease. Expect about a 40% increase over the next 30 years. Obviously, this, as Emily mentioned, this is a disease that's very common. We have effective treatments, but when left untreated, it is an expensive disease in the sense that it produces heart attacks and strokes and other complications, kidney disease, for instance. And so our estimate is that over the same time period, we would see a tripling of the costs related to hypertension in particular. And that's a really big number because it soaks up a lot of societal resources unless we figure out a way to treat it effectively.
I guess outside of tobacco, it's the single greatest cardiovascular risk factor and probably adverse effect on the population as a whole around the world. Is that fair?
It's up there right with air quality. Air pollution is now up there as number one. Among the more traditional clinical risk factors, hypertension is definitely it.
It's so interesting because when we think about a big, thorny population health issue like hypertension, we tend to think of, all right, well, maybe we start at least with the people who are here in the healthcare system, right? And I know we're going to get to some of the community-based work, Kazi, that you've done some great economic analysis on later. But like, why do you think we still are struggling so much, even with people who are in the healthcare system and going to get their regular checkups? I mean, we did a blood pressure control study using PCORNet data, sort of looking at health systems nationally. And even in people who were sort of there, had multiple visits per year, regular blood pressure measurements, hypertension control was only about 60%. So it's just striking to me that even when you focus in on the population where we should be getting this right, something is still not quite working in terms of our approaches. What do you think is contributing?
Yeah, I mean, that's a really good observation because when we think about a poorly controlled disease, we think about people who are out there not seeing their physicians, not getting care, maybe underinsured or uninsured. The truth is, people who are seeing their physicians regularly are still unable to get their blood pressure controlled. And that's a two-part problem. One is I think we as physicians are part of the problem. We see a patient, the blood pressure is slightly high, and we're like, you're not having a good day. Let's see you again in 6 months and we'll do something about it. So it's what we call therapeutic inertia. And when we built this model of hypertension care, it ended up being the major risk factor or major driver of poor blood pressure control. We worry that patients are not taking the meds. In fact, physicians and clinicians in general are not escalating blood pressure medications as often as they should. And then, of course, as you mentioned earlier, it's a lifelong condition that's asymptomatic. And so, it's easy to say, I feel well, and this medication makes me feel slightly poorly. Maybe I'll just stop taking this medication. Or life happens and, there's a major life event. And the first thing to go is, I don't have the time to refill this prescription. So it's a multi-pronged problem. And that's part of the reasons why a simple, straightforward solution may not be the answer for everyone.
Yeah, no, it's a really great observation. I struggle with this because hypertension is such a big problem. How much of it are we putting on the patients? How much are we putting on the doctors? And how much are we putting on the big organization? And sometimes it's care access and therapeutic inertia are just not, I get it. It's hard in a 20-minute visit to prescribe a
Yeah,
new medication, right? What's the state of the science on what we know or what we should be doing for people broadly when they have high blood pressure? Because there's a lot of effective therapies, right?
I would start with saying, even before we get to therapies, the lifestyle changes. Like, if you make all of these changes and can stick with them, that's the effect size is equivalent to at least one blood pressure medication. So it's the equivalent of starting one med that you can achieve by just fixing salt in your diet. And the good news here, this is not an individual person problem. This is a population health problem where we just as a population consume way more salt than we need as a species. And historically salt was hard to come by, and so we are trained by evolution to soak up as much salt as we can. Unfortunately or fortunately, in the last few hundred years salt has become abundant, and now that same adaptive mechanism that used to be helpful is now hurtful, which is we consume too much salt if given the opportunity. The fun fact is that you can replace about 30% of the sodium chloride with some potassium based substitute and have no change in flavor, and see about the effect size of two blood pressure medications, and no change in flavor at all. So you can still salt your fast food. I wouldn't recommend it, but if you did, using one of these lower salt alternatives can make a difference. That's at a population level. But in the end, I also don't want to give physicians and clinicians taking care of patients a pass. In this particular situation, we are part of the problem in terms of our reluctance to start new medications. It's a 20-minute visit. We know that white coat hypertension which is the high blood pressure in clinic, is predictive of high blood pressure at home. Maybe not consistently so, but certainly predictive. And the best, and we'll get to this, the most innovative solutions for blood pressure control often take physicians out of the solution. And that works because it sets up these automatic workflows where you have high blood pressure, I'm going to help you get on the right set of medications and support you with adherence to these medications.
We know, like you highlighted, like around one medication or 5 millimeters makes a big difference for people's lives. Two medications or 10 millimeters or more makes a significant cardiovascular risk reduction. And if you're at home listening and your blood pressure is elevated, and you could be taking those therapies or making those lifestyle changes, a little bit more activity, a little less salt, even some salt substitution, that can make a difference. We're going to get into some of the innovative things people have done on a population level or on other levels, but there are other things people should be thinking about before we get into those.
I think the other important piece is I don't notice my blood pressure. I'm totally asymptomatic, but the meds make me feel poorly. That has changed. And in particular, the medications have become better. So most people do not have symptoms from their medications. And the other is a recent development, I would say in the past 5 years or so, this clear recognition that instead of taking one medication at full dose, if you took a combination of two medicines at half dose or three-quarters of the dose, you get more blood pressure control and fewer side effects. And so for the subgroup of people who are reluctant to take medications because you're worried about side effects, it's really important to know that even just with these low-cost medications, using a combination pill of drugs, in fact, can totally eliminate side effects from high blood pressure. From high blood pressure medications. There are subgroups of individuals who might get lightheaded, may be at risk of falls, but for the vast majority of people, the bang is definitely worth the buck.
It's so interesting with all the energy and all the discussions around the GLP-1, Ozempic and other anti-obesity medications. Like those do have a direct, obvious kind of benefit. So as researchers and scientists, we might get excited about the long-term reduction in cardiovascular risk, but then for people who are feeling like, oh, my clothes fit a little bit better, I can maybe sleep better, I might have more energy, like that's a strong driver. And you think about something like hypertension, you may not have that same benefit. But I'm wondering, do you think that there's an opportunity to kind of frame the positive benefit of reducing your blood pressure in terms of a longer life or more energy, a better lifestyle, instead of just focusing on avoiding something that feels super far away?
Yeah, I totally agree. I will point out that even in the context of GLP-1 receptor agonists that make you feel better, adherence is pretty poor.
Mhm.
And so making people feel better is a part of the solution, but is not the full solution. It's like creating a wraparound solution around making people feel good about being on their medications, like you were saying. The trouble with high blood pressure is the first time you have symptoms, they could be catastrophic symptoms, right? Your first presentation might be a stroke. Your first presentation might be kidney failure. And I think impressing on people that instead of thinking of these as pills for a disease, these are like pills that help me live a healthier life, a longer life, but more importantly, a high quality life in the long term, could help some individuals stick with the medications. Also, when there are multiple choices, I mean, you mentioned there are 200 pills, but let's say I was in clinic and I had 3 pills to choose from. There's data suggesting that for some patients, engaging them in the choice of medications can give them a sense of ownership over their medications and increase adherence. So, I'm considering a drug from one of these 3 classes. This is what I think the benefit or harm of each of these meds is. Which one would you like to start with? I think even that conversation, which is not easy to do in a 20-minute visit, I realize that, but can improve adherence.
You've done a tremendous amount thinking about population and innovation, whether it's policy, science, or things that might help large swaths of people who have high blood pressure. There's some really interesting possible opportunities there. You kind of hit on one when you talked about, instead of high dose of one medication, we might have a few medications. And so some people have proposed a poly pill where you might have one pill to increase adherence, but it has 3 or 4 different medications in there. There's some other population strategies too. You want to walk us through a few of those?
Yeah, I mean, there's a long list of things we can do better at hypertension management. As Emily mentioned earlier, we're doing so poorly that anything we do, the only way to go is up. We could definitely do better on blood pressure management. I did want to start out with something very big picture, which is the 2 population level risk factors are salt consumption and weight. And so, if we're going to try and fix this, it's about changing how much salt we consume and getting us as a population to lose weight. And the latter, when we think about weight loss today, somehow our brain gravitates to GLP-1s like Ozempic. But I want us to say that really, if we're going to do this sustainably, we're going to have to change the choice architecture around food. We're going to have to think about making healthy food the default option. People are not trying to eat poorly. It's just that it's so much easier to eat poorly in the US and now globally than it is to eat well. But it's easier, it's less expensive, it's readily available. And so I think as a society, if we want to fix this, if we want to prevent hypertension, those are the 2 things we need to do. In the short term, though, what about the patients who are currently struggling with hypertension or are dealing with their own hypertension? I mentioned 2 things earlier from a health system perspective. Instead of using 1 pill at a time at high doses, using these combination pills that both reduce side effects and increase blood pressure response, because these drugs have different mechanisms. So you're basically tackling high blood pressure through different mechanisms and getting a larger effect for smaller doses of individual drugs. That is definitely a successful strategy. The second, again, building workflows so that a patient who is trying to engage in care should have no barriers to accessing blood pressure medication. So, essentially taking out blood pressure from a regular clinic into its own workflow where someone is checking your pressures, calling you periodically, or, making it so easier. You don't have to wait for a doctor's appointment to get your blood pressure controlled. That ends up being a very powerful predictor of how a health system does in terms of controlling blood pressure. And then the final thing I would say is like more broadly around adherence. And adherence is at least in part about costs. We have a health system that in the US, if we can call it a health system, that is so fragmented, but we somehow like by design, put barriers in the ways of people who want to take their medications. Blood pressure medications are extremely inexpensive. We've had them for decades. Let's go with decades. And it's not clear to me why we have co-payments on these medications. Why create a barrier at the point of prescription fill, even if it's $5? There are really compelling data showing that even a $5 copay reduces adherence at the margin, meaning some people will say, I'm really short on money this a month, I'm just going to forego my blood pressure medication. And so creating policies that allow people to engage in care at no cost at the point of care ends up being a powerful way to improve adherence. I'll close with saying that hypertension is a complex problem, and so simple solutions tend to be attractive, interesting, and wrong. Like we just have to understand that we can't use one solution for this multi-pronged problem. We're going to have to be creative. For some populations, putting care in the community is going to be the answer. For another population, increasing access by reducing costs might be an answer. And for still others, highly insured populations. So Emily, you pointed out that people who are engaged in care are still not getting their blood pressure under control. There's clearly an issue on our end. So for instance, young women are much more engaged in care than young men. And it's true that young men have worse blood pressure, particularly in some communities. But why aren't we able to get blood pressure controlled among women who are engaged in care? And so there's certainly some introspection that's needed on our end as well.
This is Beyond the Endpoint, a podcast where we bring personal and expert perspectives on healthcare and clinical research to the casual listener. Stay tuned after the interview for a breakdown with the hosts. They'll talk through key takeaways and what this week's topic means for you.
Yeah, speaking of attractive, interesting, and wrong, I was at a meeting yesterday and someone mentioned that bloodletting was actually previously a therapy that was used for hypertension. So at least we can point to that as an area of progress since that's typically on the table anymore. But Kazi, I know you've done a lot of thinking and certainly some scientific work on the concept of bringing opportunities to people to assess and treat their blood pressure outside of the healthcare system. So we talked about like the barriers within the healthcare system, which are kind of their own animal. Talk about people in the community and kind of like what we know about innovative approaches that can work well for folks who just maybe don't go to the doctor all that often, show up only if they're sick. Or what have we learned there?
I'm going to start out with two things. We did this one economic evaluation of something totally unrelated to high blood pressure many years ago, which was to look at people with rheumatic heart disease when they have to get a certain treatment. Children have to get an injection to prevent further recurrences. The reason I'm bringing this up is we found that when you look at the cost of treatment, the cost of the drug was only about a third of the cost of the therapy. 1/3 was the time that a parent had to take off to take the child for care, and the last third was transportation costs. And so when we think about barriers, we underestimate the total cost that the patient is facing. It's more than just the copayment for the medication, it's taking time off from work, it's the transportation cost. Maybe for an older patient, that involves bringing someone else with you to the doctor's office, especially for individuals with language barriers, may feel like a child may have to take off from work and come with them. And this is where solutions that are based in the community come into play, because they can eliminate the transportation costs. Maybe there is a language concordant provider who can be in this setting. But there is the second piece, apart from costs, and that's about trust. So even among individuals who engage with the health system, we know that one of the strongest predictors of whether you take your medications or not is your relationship with the clinician. If you know your clinician, you trust your clinician, they're more likely to take their medications. The most famous example of this was led by the late Dr. Ron Victor and colleagues, where they brought pharmacists into Black-owned barbershops. So Black men who have historically had both high rates of blood pressure and poor rates of control and catastrophic consequences from high blood pressure don't engage as much with the health system as other members of the community. And so his question was, what if we brought the blood pressure care to them in the barbershop? You're familiar with the results, 20 millimeter mercury improvement in blood pressure. I mean, very large effect sizes. But one of the things I learned from the process is a lot of the mean duration of relationship between the individuals in the trial and their barbers was, you want to guess?
6 years?
10 years.
Wow.
Very long, trusting relationships between individuals and these other members of the community whose opinions they value and trust. And so, in that environment, if they were to get care, and again, it was not just the fact that it was in this environment. I worked with some of the pharmacists who were engaged in this experiment. They cared deeply, they were engaged deeply with their patients, they eliminated the co payments. So, there were many things that were going on there to make it easier for these Black men with high blood pressure to get their blood pressure under control. But then you saw these impressive results that we don't see in health systems. This experiment has since been replicated in other contexts, or it certainly is being replicated in other contexts. So could we take blood pressure control to churches and to other community centers where people have long-standing, trusting relationships with members of the community? And like I said, I'm optimistic about this because it demedicalizes hypertension. It acknowledges that a lot of us have this condition, a million US adults, that it's easy to treat. It can happen in a trusted setting. You don't have to go into a hospital to get care for blood pressure. And that's one of the many solutions it's going to take to fix this problem.
That's really, really valuable, Kazi. And I guess maybe we might round it out here because we sort of talked about the population. We talked about what happens in clinics. We talked about removing those barriers, whether it's in the barbershop or the communities. Maybe we should talk about salt substitution as an interesting opportunity because salt substitution is a place where I think we could be doing much more population-based actions. Tell me about what you think there.
And the idea of salt substitution is to replace sodium chloride with potassium chloride. Past 30%, the salt starts to feel bitter and people notice a change in different, like in taste. But up to 25%, you barely even notice the difference. You won't notice the difference. You can't tell the difference. So in individuals with normal kidney function or who can handle the additional potassium, you see pretty substantial drops in blood pressure. And in fact, these trials, which have even shown it's not just blood pressure, all the side effects of high blood pressure, cardiovascular morbidity and mortality go down by about 10%, 10 to 15% reduction in these cardiovascular outcomes, the things we don't want happening to people. And so salt substitution is attractive because it feels like almost like an engineering solution, right? If you take the choice out of it, you make the healthy alternative the default. And the way it would work in my mind is if we could strike an agreement with, say, fast food providers and push them to substitute the 25% of their sodium chloride with potassium chloride. I mean, it's a separate question that there's probably already too much salt in it to begin with. But even if we just substituted a quarter of the salt out, we could see changes at a population level. And maybe there's an opt-in that if you want a full 100% sodium chloride option, which some patients may need because they can't handle the extra potassium, you can opt into it. But if you don't say anything, you get something that is slightly healthier for you, though it's hard to think of fries as healthy, but let's just go with that.
Necessary, maybe, but not healthy.
And a major place where it's worked, actually, we're talking about fast food, but some of the best experiments have been around bread. So
Yeah.
bread uses a lot of salt, as you know, and particularly in cultures where bread consumption is very high and high blood pressure is very prevalent. So think South America, for instance, and parts of Europe. If you substitute the amount of sodium chloride, like a certain proportion of sodium chloride in commercially available bread with potassium chloride, you see population level changes in blood pressure. And that's changing the default option. So now when I go to the bakery and buy a loaf of sourdough because I love it, the salt in the bread is now partially potassium chloride.
It has been encouraging to see additional dialogue around some of the things that we take as the way that food should look. For example, in the US, that you look at Europe and they don't do things that way. And so there's been more conversation, which is, I think, a good thing. And maybe some of this salt substitution kind of dialogue can be part of that as well. We'll see.
Yeah, I certainly think that the biggest things we're going to be challenged with it. You mentioned air quality and other things, but as we think about high blood pressure, in addition to air quality, is just going to be as we go from an industrialized world to a local world, and how can we go back to getting food that's close and not processed and potentially support those things. Those are really hard. as the population's increased and the world has to be fed. So I do think those are some of the things that are going into that architecture of what people get offered. But, societies have figured it out outside the United States in some parts of the United States. So I don't want to be too negative on us figuring it out. I just know that we're going to have to come up with other ways to encourage people to do it.
Kazi, you've convinced me about the salt as an individual a little bit. I'm going to try. But I'm curious, what should we as individuals be advocating for? Like when we're thinking about voting or writing letters to our Congress people or to corporations, what are some of the one or two big things we could be pushing for to help everyone?
That's a really good question. I'll take the win, even the fact that you've gone from salt is my weakness to I'm thinking about cutting down on salt. I take that as a win. So thank you. I think that as a society, I'm going back to the comment we made earlier, which is that there's no way to address this without fixing what we eat. In the end, we can talk about weight, we can talk about salt, but it's essentially a function of food. And so many years ago, back when the earth was cooling and I was in graduate school, I took an accounting class and had an accounting professor who said all behavior is incentive compatible. Part of the reason the food system in the US is broken is because the incentives we offer the food industry are broken. We subsidize some of the unhealthiest foods and make it harder for individuals to access healthy food. And so advocating for policies that allow access to fresh fruit and vegetables and diminish access to sugar sweetened beverages, for instance, would be a good place to start as we advocate for better food. It'd be a twofer. We'd help address the overweight and obesity crisis as well as the hypertension crisis in the process.
That's great, Kazi. And I think you're right. There's a lot of opportunity for us to advocate for those sort of local solutions and even global solutions. We really appreciate your willingness to join us on this wide-ranging conversation. I come back to your comment about ideas that are attractive, interesting, and wrong. Hopefully, we've provided some that are right and some that are going to get put into practice. It's really great having you. Thanks for joining us.
Thank you so much, and I'll look forward to your hot sauce recommendations.
Well, that was really fun. Drew's just a fun guy to talk to, and it's just so smart and goes through so much data well. And Emily, you think about the population health a lot, and we did talk about where the world's going. Any take homes for you from Kazi's conversation?
Yeah, it seems like, for this one, simple, easy solutions might be a bit of a double-edged sword. Seems like we have a lot of tools in the toolbox, but we can't expect them to work in every setting and for every person. So flexibility, I think, both on the clinical side in terms of, having to maybe try a few different things before you achieve control, and on the research side that maybe our interventions are tailored specifically for certain groups, and that's what it's going to take to really bend this curve. So I would say embracing the complexity and being cautious of anything that's attractive and interesting or maybe seems too good to be true, because it could also be wrong.
Yeah, and I'll just end by saying for our group, it's a big problem and we need a lot of thought and work on it, but we really appreciate everyone listening because I think there are some really, really good ways that we can individually help, but as a population help also.
I think the takeaway for patients as well, folks like myself, is to think not only about your own health, but to think about your community's health and the choices we're making as individuals, but also the kinds of things that we're advocating for.
Yeah, for sure. And I actually think it's a lesson we're going to continue to come back to as we think about how we improve not just our health, but our community health. Well, thanks everyone for listening to this episode of Beyond the Endpoint.
This has been Beyond the Endpoint. Resources related to this episode are available on dcri.org/BTE. If you have any burning questions about clinical research or healthcare, drop us a line at beyondtheendpoint@duke.edu. We'd love to address your questions in a future episode.